All right, ladies and gentlemen, we're entering our final section of our 12 lead EKG interpretation class. In this last part, I'm going to go over some unique scenarios, but specific and highly valuable. Either having high or low potassium, high or low calcium, and good old-fashioned digoxin. These are broad strokes, but it's going to be enough to give you a general idea of what to look for in real life. So hyperkalemia, simply put, you're going to have tall peaked T waves, wide flat P waves, wide QRSs, disappearing ST segments, merging QRS T waves. A lot of little details. But what's really going to be important is, if you think back from earlier, we had the intraventricular conduction delay. And hyperkalemia is one of those great sources for that. Ultimately, the stuff we're going to focus on is these peaked T waves, and that you can have these wide QRSs that cause the ST segment to disappear altogether. Your P waves will flatten out. And so ultimately, instead of having a nice PQRS T wave, is that you lose your P waves, your QRSs get really wide, and then you essentially don't have a T wave until everything really goes to pot. What the worst scenario that can happen is, as you progress through a continuum, the next step is that you actually wind up with something like this, which is known as a sine wave. That sine wave is then going to progress into good old-fashioned asystole. That's the real problem with hyperkalemia, is that it just gets to the point where there's so much extra potassium, repolarization doesn't happen at all, and it just flattens out completely. Usually you don't see changes in general until you're greater, so you're pretty safe until you get higher than 5.5 with your potassium. But again, it all depends on how acute that change is. You got your dialysis patient, they live at maybe, a 6 sometimes, or a 7, and that's just their normal every day. Their bodies have gotten used to it. Rough outline just with this one, kind of look at it, use it as a guidepost for the remainder of your career, or you can always look it up. But T-wave stuff is early. 6.5 you get the interval change. At 7 you start to see P waves act funny. You get greater than 8, losing your P waves isn't the only problem you're going to have. Lots and lots of other stuff is going to occur. So let's walk through. I've already taken the liberty of filling these out to just try and save time. This is a tough one. This is a fun one. Take a minute, absorb it, look at it, and we will go through this like we always have. Heart rate is about 40. If I had to give it a rhythm, I would say that it's probably an idioventricular rhythm. The problem is it's too fast. I would expect an idioventricular rhythm to be down in the 20s, and this is sitting in the 40s. So it seems really fast, but it just looks like a long run of PVCs, doesn't it? Except for it's perfectly regular. Anyhow, walk through the stuff like I usually do. I've got a left axis deviation. I'm at up negative 60 degrees. I'm going to look and see if I have a left anterior hemiblock. Do I have the up, down, down pattern? I have up, down, down. So I'm going to say I have evidence of a hemiblock. So that's good to keep in mind. No delta waves. My QRSs are crazy wide. And because they're so wide, I don't know if I can really truly diagnose a left ventricular hypertrophy or right ventricular hypertrophy. We talked about that before. But what I can look for is bundle branch blocks, and that brings me to step 6. So let's look at V6 and lead 1. And here I would probably say a more slurred or sloping S wave. And the same goes for here. I do not have my, so I'll have, so I've got criteria here for slur, but my V1 does not have the R, the RR prime that I would normally expect. And so what that does is say it's almost a right bundle branch. Well, let's look for a left bundle. What would I expect? Well, I don't have the rounded appearance here, but I do have rounded QRSs here, and I have the deep rounded there. So I kind of sort of have what I need to do a left bundle branch block as well. So it's a bit of a mix for both of those. That right there should be enough for you to think that it's an idioventricular conduction delay, and you can kind of stop there. Just for practice sake, because I want you to think about these things, do a walkthrough. Do I have ST elevation, ST depression, things of that nature that I could probably diagnose? The answer is I should, because of the conduction delay, but let's apply those knowledge points. So here I'm positive 2 millimeters, positive 1, positive 2, positive 1, negative 1, negative 2, negative 2, negative 2, and these are +1, +3, +2. So I have elevation in 2, 3 AVF, and then V1 through V4. So that's a lot. That's a inferior anterior septal MI right there. In terms of Q waves, I have QSs out the wazoo. I've got, this here is a QS. This here is a, is a QS. The 2 lead is very nearly 1. And so because I have those two, I've got QS in 3 AVF. Not a good sign, of course. It means there might be a posterior infarction going on, and that's not good either. So now I have an anterior, a lateral, and anterior and a posterior infarct simultaneously. That's crazy. In terms of ST depressions, I have that in my lateral leads. So in my V5 through V6, my 1 and my AVL all have depressions. Now, if I have an infarct in my anteriors, the depressions in those lateral would make sense, so those could be reciprocal changes, except for they have inverted T waves, and those inverted T waves are a sign that it's an actual ischemic event going on. Meanwhile, my ST elevations have upright T's. And those are down. But what about my T waves? Well, holy cow, look at how peaked that T wave is on so many of these leads. Even the inverted ones are pretty sharp in the direction that they go down. Also mention that there's no P wave. So let's go back a couple slides. Flat P waves, wide QRS. My ST segment has essentially disappeared. Merging of Q, S, and T waves, tall peaked. We hit all the criteria for hyperkalemia. And that's honestly what we're going to go with. So this was probably a sinus rhythm or a bradycardia. Impossible to tell without the P waves, but ultimately it's going to be intraventricular conduction delay, and we're going to check labs to see what's going on. Probably need a pacer for this guy to get, or gal, to get them through what's going on. Ultimately, we know they're high because they've lost the P waves. I'm going to go back one slide. And that they're probably in this 8.8 range, somewhere in there. And in fact, this patient had a potassium of 8.3. Again, what we're worried about is that these QRSs will eventually turn into this sine wave and then eventually just flatten out altogether. So, do the treatments, get them what they need. Flip side of the coin, hypokalemia, we're running low. What happens here is instead of a single T wave that you would normally expect, you actually get the appearance of something called a U wave. U waves are a little bit of an enigma. There's not perfect information explaining what all that is, but we know they exist. We can see them on a fairly regular basis in the right circumstances. Hypokalemia, not quite as dangerous as hyperkalemia, but we still need to replace it as quickly as possible because of the risks that go along with it. If they happen to be on a medication that requires potassium, like Digoxin, hypokalemia can become very deadly very quick. So, details. If you're going to see a U wave, particularly in hypokalemia, you're going to see a few things. You'll probably see them in V2 and V4. They're not terribly big. They're the same polarity as the T wave. They occur just after it. So you'd have a QRS, T wave, and then a U wave. Scenarios that you would see them, hypokalemia I mentioned. Some bradycardic patients, you may actually see it as well. People getting these antiarrhythmics are going to get into trouble. Good example would be the quinidines. Amiodarone and good old-fashioned Digoxin. Intracranial hemorrhages. So CVA type patients or just any kind of damage to the brain, bleeds in particulars are really big for this. And then congenital long QT syndrome. Whole lectures can be put in on this one, but we'll basically say that in the long QT folks, you might, instead of seeing what we have up here, is that because that QRS and there's a longer time before the T wave starts, that the U wave is included with it and that they're being combined together. All right, so that's hypokalemia, talking about U waves. Hypercalcemia, what really happens here is your QT interval gets shorter, so that this space tightens up quite a bit. Hypocalcemia, so low calcium, prolongs your QT intervals. What a surprise, those things work the opposite. Just like with potassium, lots of it, high T waves. Not enough of it, U waves. It actually flattens things out quite a bit. So prolonged QT interval. Everyone thinks of long QT syndrome, as they should, which is an important thing to be able to catch. However, what we see on a daily basis is more likely a situation where it's an acquired long QT syndrome. And that's usually due to, not a surprise, medications. So long QT syndrome. All right. Ultimately, it's a repolarization disorder. You're not getting your T wave created. You're not recharging your ventricles as quickly as you should. And so what happens is you've got your PQRS like normal, and then you have this long space before your T wave happens. And oftentimes your P wave is right on the heels of it. And you wind up with a situation like this. It's a high risk for Torsades, TDP. Polymorphic ventricular tachycardia is the other name for that, in case you were wondering. Primary symptoms. I'll talk about the causes in a second, but the symptoms that you're going to see most often for these folks is going to be palpitations, syncope, seizures, these are all things that make sense when your heart is skipping beats or taking too long, or maybe just stopping altogether for periods of time. Death is also one that can happen. So causes. What are our causes? Well, the antis, as it were, are big sources. So antiarrhythmics, antibiotics, antipsychotics, antidepressants, tons. There's hundreds of meds that have been linked to causing prolonged QT interval issues, whether the person has a genetic predisposition towards it or not. It's a scenario of multiple hits kind of adding up over time. Medications, just to kind of list the big ones: amiodarone in the face of hypokalemia, plus amiodarone is a great one. Intracranial disease in general, I don't have a specific list for that one. Hypothermia is a great one. We always have to watch out for a prolonged QT interval when we cool people down, which makes sense. You drop the metabolism, that can mess with your repolarization. But the reason why it comes up today is the earliest phases of cardiac ischemia, MI, have a really good risk of having prolonged QT and the problems that go along with it. What we're looking for is a QT that's less than 460 in general. That's ideal. That's also known as 0.46 seconds. That's what we're shooting for. If it winds up getting long, you then wind up with a number of problems. It can either be Brady, you can have AV blocks, or even third degree heart block can come out of this as well. So let's play with some examples. Pre-built, as said, heart rate's 90, sinus rhythm with a first degree AV block We're in the normal quadrant. Isoelectric is lead 1, which gives us a positive 90 mean QRS. We don't have any delta waves. We do have left ventricular hypertrophy, though, because we have 27 plus 12, so that's for real. But the R and S ratio is not quite what it needs to be in V1, so we don't have right ventricular hypertrophy. The P waves, while they may seem peaked in lead 2, it's tough to get a real beat on it to say if that's true, right atrial enlargement. But if we look at V1, we can see that we have mu waves, particularly that the first half is greater than the second. That might be something too, but what's weird is if you stop and look, where's the T wave at? And I'll look at the lead 2 at the bottom, and we can see that we have our PQRS, our T wave's way out here, and then that's the next P wave. So I don't think we have P pulmonale as much as a T wave, or even P mitral, as much of a T wave falling on top of the P wave. So I don't think we have any kind of atrial enlargement. Wide QRS, no, we don't. However, if we do measure out, and we'll use our 2 lead, the QRS, or sorry, the QT interval through here, well, that's 20, that's 40. You know, we're shooting in that 460 to 480 range. So that's an awful wide QT interval. Last thing we'll look for is the same thing we always look for, which is going to be our ST. So we'll go long QT. All right, so step number 7, what do we got? Well, we really don't have a lot. We just have some really non-specific odd changes. You look in V2, maybe that's your T wave, maybe it's not. But if that's your T wave, what's this here? Same thing goes here. We've got some space, but we've got this lump here and this lump here. The same thing, if that's our P wave, I've actually got this double notch here. And I kind of have a similar thing through here and here. So what do? We kind of, maybe I've got Q waves, but these are tiny. They're pretty snug. They're probably not pathological in any way, or pathologic, I should say. So I'm going to say none for that. I've got weird ST sloping. All my T waves are upright. I don't really have any depression that I can find. So I don't think we have an active MI. What happens, though, is our labs come back. And let me change my color back to red here. Our labs give us a potassium of 1.6. So we have a massive case of hypokalemia. Knowing that, what do? We go back and we look at the things that matter in this case. And I'm going to go back a couple slides. And as you can see, we get the appearance of U-waves. And these U-waves are generally in which ones? Leads 2 through 4. And tend to have a decent voltage. So let's go back. And if you look really close, you'll realize in lead 2, 3, and 4 to a certain extent, that we may actually be seeing this is the T wave, and this is the U wave. This is the T wave, and this is the U wave. This patient, because their potassium is so low, actually has tall U waves. And that completely changes everything, doesn't it? We don't actually have a long QT. Those were actually U waves that we were seeing through here that we're throwing everything off completely. So this patient winds up having sinus rhythm with first degree AVB and U waves. If we had picked up on the U waves earlier, because we're learning now, that would have prompted us to go, oh, well, it's not just a case of a little bit of, odd looking EKG, but that may actually be worth digging into. And it depends on your patient's symptoms too when they show up. 503. Walking through it, we have a heart rate of 98. We're sinus rhythm, normal quadrant, positive 30 degrees. There's no delta waves. Lead 2 and V1 may or may not have a P wave. Again, we've got this odd thing, and I'm going to do this down here at the bottom where I've got my PQRS. I've got a long space, a dip, a lift, and then right back in. And so I need to figure out what's going on through there. I can't see the start of my P wave, so it's really kind of hard to tell how tall it is and what's going on. So I can't say if I have atrial so much. If I look in the V1 though, I could probably make an argument for left atrial enlargement. I think that's reasonable. As for a wide QRS, we definitely don't have that. So let's look for a heart attack. Start scanning our leads. What do we see? There's no changes here. Maybe a 1. Nothing here, but we do have inverted T waves. And I would say that these are inverted as well. Definite inverted T wave, normal. And so I say a negative 1 millimeter. Maybe through here a negative 1 millimeter as well. We'll check out our other laterals, nothing too exciting there. We'll check out our inferior leads. Not going to be able to give you much on that. They have upright T's as far as I can tell. No Q waves, so we don't have that there, but we did have we had a little ST elevation in V2, but that's just a single lead, so that doesn't give us a ton. We did have depression in 2 through 5. Oh, sorry. V3 through V5. With inverted T waves. What else do we have? Well, reciprocals. Let's ask the question. Could this be reciprocal of something? You know what? Not really, because what else do we have going on? Well, I mentioned it before. It looks like that QT is off base. And so if I try and measure my QT again, we'll start right here. And if I assume my T wave ends where it's supposed to, that is 2040. Yeah, that's almost, should be about greater than 500 milliseconds or greater than 0.50 seconds. So I have a long QT for sure. And because that's a repolarization issue, that slow repolarization could be what's causing my 2, 3, and 4 to be out of whack. So let's go back to our long QT for just a second. And we really don't have any specific criteria other than the repolarization part of things. So what we need on this patient would be a history, either family or medications, and if they've been taking any of those anti-medications, antiarrhythmics, antipsychotics, antidepressants, whatever, that could have stacked up and caused their QT to elongate. We're going to want serial EKGs to keep an eye on this patient to see what's going on. If they've had any kind of new meds, we need to stop them immediately. But honestly, this is just sinus rhythm with prolonged QT. A little more fun. What do we got? Starts out with a heart rate of 80, kicks into torsades. They were in sinus rhythm, had bigeminy PACs that were having aberrant conduction, but they were also having R on T phenomenon, and you can really see it here with that R on T. We can go ahead and measure it out, though. We have upright in one end AVF, so we're in the normal quadrant. Our isoelectric was AVL, and that gives us a positive 60. So they weren't really too far off with their mean QRS to start with. They didn't have any delta waves. No signs of right or left atrial enlargement that we could tell. In terms of right and left ventricular enlargement, impossible to tell because of the polymorphic VTAC that they went into. We don't have a wide QRS early, but there's not much else we can get into. And we'll ask that question. Can you tell me what the QT is? Obviously, we're on a theme, but the question is, what is the QT, or what could it have been? And it turns out that this actually is a case of prolonged QT, and what's happening is it was so far that this is actually the T wave here, and that you are having early beats step on where it should have been, and it's this bunching up that occurred through here that caused them to jump into this rhythm. So we did have a prolonged. Now, before we go ahead and accept that as our answer, we should always do our usual workup on the parts that we can. You know, do we have any ST elevation prior to going into this lethal arrhythmia? And nope. No elevation, no depression that we can really tell anywhere. In terms of Q waves, don't see those. No depression. So there's really a whole lot of nothing there. Things are going fine. The backstory on this one, and I like telling the backstory with this one because it really puts a point on what goes on. So this patient previously was into the ER, was having dizzy spells. Her EKG is actually the one on the previous slide, number 405 or 403. That was her EKG in the ER. A little bit of long QT going on. She was coming in with dizzy spells. No one noted the long QTs when she was being. This was like decades ago, so just don't get too fired up. Getting worked up for these dizzy spells, nothing happened. She goes in a couple more times. They get her a psych consult, and psych misdiagnosed her with a psychiatric disorder, and she gets placed on tricyclic antidepressants. This literally, 506, was her last EKG when she came into the ER. She went into this rhythm while being monitored and continued to deteriorate, went into VFib and did not survive. But it illustrates that point of catching these long QTs and that what can truly happen if they're not recognized and taken care of. Official list of common drugs that prolong QTs. They have additive effects, so if you put a couple of these together, you can get yourself in a world of hurt pretty quick. final one. Also not terribly pretty. If you look closely, you'll see you have a ventricular rate of 60. You have an atrial rate of 150. You're sitting in a lovely complete heart block with accelerated junctional as your escape rhythm. You are in the left axis deviation with a negative 60 mean QRS. Do you have left atrial hemiblock? Well, we have our criteria of up, down, down, and the answer is yes, we do. So there's definitely some left left anterior hemiblock. No delta waves. We don't have any atrial enlargement from the P waves that we can see. No right ventricular enlargement either. However, the left ventricle is really close. It's got a 33 millimeter addition, which I've marked out. So you could probably argue one way or another on that. We don't have a wide QRS. In terms of measuring our QT interval, having a difficult time getting to that as well because of what's going on in the P waves, but we're going to say no QT lengthening. We'll do a quick workup for an MI, see what we can find. And all we really have is maybe some T wave trouble, because that T wave's kind of flat. That one's an inverted T. These are all upright. I don't have any S, maybe just the tiniest of ST changes on this one. A little bit of depression. My lateral leads look fine. I have uprights here, here. I do, however, have a bit of a QS going on through here, which is important considering there's not an actual bundle branch block. In fact, even V1 is trying to do a QS as well. And so those are continuous leads, and QSs are never normal. So something must be going on, particularly affecting the inferiors. And let's be honest, he's in a 3rd degree block, so something must be going on. A little medical history with this patient, and it turns out their digoxin level is triple what it should be. And that's the big thing. So we have QS in 2, 3, BF, and V1. Switch to my red here real quick. And the big lesson is this: digoxin is a tricky drug. This here, a 3rd degree block with a junctional escape, is the most common thing you'll see with digoxin poisoning. However, dig can look at like almost anything. It can cause tachycardias. It can cause any degree of AV block. Your potassium's important. The amount they're taking, getting dig levels is the big take home here. But just because you see a 3rd degree heart block, don't assume it was an MI that caused it. It may actually be medication related. And that is the final slide. Thank you so much for playing, guys.